to answer the health insurance. Ebooks explain the logic behind the code for each surgery. Recorded masterclass session, monthly webinars, live training, all types of education system to learn for to members how to use this guide of coding to spine surgery, neurosurgery, and everything. And for our surprise, in the United States, it starts the same project, guide to coding of neurosurgery, spine surgery, and everything part. How is the impact of members' opinion about the coding guidelines of neurosurgical procedure? This graphic show the opinions of our neurosurgery that use this new code guideline code to order your order than their surgeries. The most part you see is good, very good impact in real life in Brazil. How is the economic impact of coding guidelines of neurosurgical procedure? It's the monthly incomes of general neurosurgeon in Brazil increased more than 400%. And then, how is the impact of coding guidelines in the other medical society in Brazil? We start in Brazil using this form, this guide of coding in neurosurgery, spine surgery, and then after this, code idea spread to other medical society like a virus. So specialty society started to approach me, ask me, how we please help us with our code guidelines. I don't know why, but I accept. I say yes for all. So, like an avalanche, at least 10 other medical societies start to work with this system, coding system to organize and standardize the manual, the guide of coding for each surgery specialty. It's some example of guideline, the other specialties. And about the future, how can we change the next neurosurgeon generation? We can implement a new code into the neurosurgeon before they are born. Implement a new skills into the resident program. We have 10 residents for years born to healthcare system. So in the final, we have a big SBN arm to combat of healthcare abuses. The origin story of the Brazilian code guidelines. Before I conclude this part, I must share with you where I got the idea of coding. In 2029, during my observership at Barrow Neurological Institute, I had the opportunity to attend the CNS conference in New Orleans. So, two things remember me in my mind, this conference. First of all, Bourbon Street, you remember this Bourbon Street? Yeah. And New Orleans. The second part is a coding session in CNS conference. During the conference, I found a code session. Code up to date. What is this? Who's care of this? I said in the app. Let's change the room and see some surgery and forget this objective. So, but 7 years later, this memory become inspiration, an idea, an opportunity to change of things, to change of salary, to change of system of coding in healthcare Brazilian system. And then we created the guidelines of coding to neurosurgery, spine surgery, and the vascular surgery, and the other specialty. It's more action of our society to improve the neurosurgical practices in Brazil. Stop the open new surgical residents, like a damage control, careful review of the current resident program, closing some claudicated residents, monitoring system into our society, WhatsApp groups, capture reports, make the notes, conflict mediations, contract negotiation with the healthcare system and hospital, counterattack against the healthcare system abuse, partnership SBN in São Paulo Superior Court, SBN as a audit company, partnership and SBN and banks and the other enterprise. We create SBN insurance, medical liability insurance for all. So what is the next? We start a new project today in Brazil, this year, in my actual manager of the Neurosurgery Society of Brazil, using artificial intelligence. Let you see a little. It's a recorder, medical recorder, common medical recorder with a coding system. A part of this system help the associated, help the neurosurgeon to construct the coding to each surgery. Let's see. First, you shows you the coding guidelines, spine surgery or neurosurgery. You can type the surgery, tumor, degenerative spine surgery. You choose what kind of the surgery, and then you choose the codes, choose the materials. It's ready to share with the healthcare system, hospital, your secretary, your patient, everything. And then when the insurance deny, you can create the response to healthcare system using artificial intelligence. So it's my presentation for this morning. Thank you everybody for coming, and now I finish my presentation. Thank you everybody.
Thank you, Wilker. Actually, we have very close communication in Russia in the direction of BRICS spine with Brazilian society. Thank you very much for your always communication, and we have in Russia close communication with Brazil spinal surgeons. We have publication normally in columnar journal regarding our spine direction. And if we have questions for the speaker, I'm personally would like to ask: do you manage in Brazil to conjunct the two specialty, orthopedics and neurosurgery? I mean, do you have the spine specialist as well, or it's still separated? And do you have probably spinal department like like also communication of two specialties? Just your comments regarding it.
Thank you for question. The orthopedic surgery, spine surgery, is born by a resident of orthopedic, and then in the final, neurosurgery resident and orthopedic resident match the same society of spine surgery. Brazilian spine surgery is society share with neurosurgery and orthopedic surgery, but some programs share with or accept residents coming from neurosurgery or coming from orthopedic surgery. We work together very well.
Thank you. Is there any question from participants or from our moderators, please?
I have a question, please.
Please.
Yes, Dr. Victor, thank you for your excellent presentation. I understand you stand about abuse in the practice, and what about corruption? You talk about corruption, and what your plan to fight against?
So these systems we create the guide of coding. It's increase the salary of a surgeon, and then when do you do this, we decrease the way to corruption. You can understand me? So it's a type of our society get to combat the corruption in Brazil. Increase the salary, increase the incomings by code, by proceed, pay a fee for service, and then when it's happen, we can get balance and decrease the materials corruption, and everything is well.
Okay, thank you.
Thank you, Joe.
Other questions? A question from the floor. Is there universal insurance for the medical care in Brazil and Chad for public health?
We have yes, we have a public system. It's 70% of practice in Brazil of neurosurgery, and the other part, 30%, we work with private system. But the most part is public system, and you have a lot of problem with fee for service and public system materials. And Marcos Mazzini talk about this problem.
Okay. Can we invite Marcos Mazzini for his talk, the second speaker in our conference, please, Marcos?
Thank you for the invitation. Thanks to Professor Salman, Professor Pio, the other organizers. It's a pleasure to be back to the discourse of the Spine Committee, World Spine Committee. I've been participating of this committee for many years, and what I did, I knew that Walker would approach all the basics. I did a brainstorm with my team, and we decided for 10 items that I will discuss with you. It's not exactly in the order that it could be important, but I would like to talk about this. I hope this discussion is being taped, The first thing is that probably we will, with the ideas, develop a structure to analyze other areas of the world. And probably this analysis will help us, even we from South America, to solve some of our problems. Because my impression is that this is happening all over the world. And many of the problems we face here in Latin America, other areas and other people have been facing, and probably they have been finding some solution. So this is the first thought that came from our brainstorm. The second is that here in Latin America, there is a very high cost to pay for innovations. And usually innovation arrives after some time. They have been developed in a first world area. And when they arrive for us, usually they have very high price. And this is a circumstance that we cannot face with a low income country. I think that it happens in all the countries of Latin America, and that is a limitation to our work. I don't know how to face this situation. Of course, we will discuss. The second idea is that we are very far from these creative centers. They develop the system, the devices, they produce the devices, and usually there is no connection with our reality. This is the second problem. We have received very high price for the devices, and they are not useful to our population. This is a good discussion also. The lack of support to industrial research. This is another problem we face. Most of the neurosurgeons and orthopedic surgeons, they are well trained here in Brazil, Latin America, and they have training in the United States, in Europe, but we don't have organization to support their research, which would be very interesting because they would research on the problems of our country, of our situation. In Brazil, we have areas which are very well developed, for example, São Paulo, but there are many other areas which is poor in the healthcare, and they face very basic difficulties. So these differences make it very difficult to organize a good system of healthcare. So there is a need for integration.
Marcus, sorry, I'm interrupting you. We don't see your screen. We don't see your screen. Do you want to share your screen?
No, my screen is my face.
Okay, well, we will go with that then.
Yes, no, I mean,
there's no presentation. I mean, it's okay.
Yes.
Okay, Marcus, we're listening to you. Okay.
But after I can send you all these I have written on the side of my telephone, so I can send you all these ideas. I hope you are taping so you can review and go further in my thoughts. Okay. Need for integration of this organization of the medical care. Usually, there is a focus on the specialists. The neurosurgeon is on the front, and many of our problems in spine could be dealt with a general doctor, a medical doctor. That would avoid the vision of a specialist at first sight of the disease. That is expensive and many times do not increase solution. So due to this, there is inadequate facing to the evolution of the pathologies. What I mean is that we have patients, same pathology, but in different stage. For example, a tumor that is just starting to give some sensorial deficit, and a tumor that increase in size, and you see the patient paraplegic. So we have to treat the disease in many phases, not in the initial phase, as we see most of the books bring the solution. So it's difficult. And many of these patients come with many other complications associated to the disease. And the economic condition of the country is other thing incompatible. When we require some kind of technology. So we think that there should be some ideal appropriation of technology for low-income countries. And we need some stronger or more aggressive lobbying actions with the government, as Professor Wilker showed. We have to work with the authorities. We have to work with the legislative power to change all this relationship. But Wilker showed that we are advancing in this area, and I think it's very important with the other things that I have mentioned. So I still think that we have to follow with this debate. Next World Congress, we will have a forum. This for affordable neurosurgical technologies and techniques for low-income regions. You understand that we are organizing the World Federation Congress in South Africa, and this is a region where we have a much more number of countries with very low income, and the discussion will be how to afford the technology and the techniques. So just to you, I would like you all to, you are all invited to come to the forum in Cape Town, 6 and 7 of this December. And just to you know some of the topics that we will approach. For example, how to manage complicated case and most complicated case in small and poor neurosurgical unit. Just to mention another topic, the role of the compressive craniotomy in centers with no intracranial pressure monitoring. Another topic, how South American neurosurgeons face their practice difficulties, and so on. There are more than 20 topics and presentations in this forum, and probably the idea is that this forum is an extension of what we are doing now, discussing the problems in our region. I thank you all for the attention, and I promise I can send you a summary of all these comments. Thank you very much.
Thank you, Marcus. Okay, we can discuss this this talk. If possible, I can one comment. You know, due to some political situation, our country, Russia, is now living in the situation of sanctions. I mean, you told Marcus regarding the economical, geographical restriction which come in for the years, and we suddenly face in Russia the problem that we are completely bordered and restricted from any import for some direction. And I just share my personal impressions of it. I mean, that's we thought that probably Russians can produce some own national technologies, but it's very expensive, much more expensive than to buy technology in other countries. I mean, we can import it from China because we have nothing sometime for support our medical surgical directions. That's why it's very interesting discussion exactly how the country can live in some situation which coming unexpectedly. That's why your talk is very important and very interesting to probably discuss how to manage in this situation. But okay, I think we can also discuss it during the Cape Town WFNS meeting because it's very long and very interesting facing of this problem from the different sides. Thank you. Any questions to our speaker?
Yeah, definitely interesting discussion. I just want to make a short comment as well. I was going to say that local production and local manufacturing would be a solution to that, but what you're saying, Artyom, is that your local production is more expensive than to import it. Well, my logical thinking is it shouldn't be like that, because if you produce locally, it should be cheaper. So maybe there is some industrial phenomenon to that. Maybe, I'm not sure, maybe somebody's taking advantage in a situation that you're at the minute or what's happening, but I used to work back in Bulgaria for the first half of my neurosurgical career, and I remember that let's say pedicle screws from Medtronic were way more expensive comparing to same or similar size and similar quality pedicle screws produced in Turkey, for example. And then when I go to Pakistan, Salman is telling me that the pedicle screws, which are from Medtronic, which cost about £2,500 in UK, are less than $200 in Pakistan. So for sure, local produce is a way to look into that, but it's again a long discussion, and it's not only what we want to do, but also there is many other factors. So for sure, I think it would be interesting to discuss that in Cape Town.
Thank you.
Thank you.
Thank you.
Okay, shall I announce the next speaker? It's Dr. Sugar Hinojosa from Peru, and we invite you for your presentations, please, doctor.
Good morning. I'm going to share my screen. First of all, thank you for the invitation to Nikolai and Professor Sharif. We know that today is his birthday, so obviously it's going to be a little difficult for him to be with us. So my topic is importance of radiological planning for spine surgery in low medium income countries. A little bit of myself. I have been neurosurgeon for 5 years now. After I finished my formation here in Peru, I went to Nepal, to Bhimbira. I spent and I made a school-based in microsurgery fellowship with Professor Ivory. And then I have the opportunity to be also in China with Professor P, with Professor Sharif, and some courses of spine, which is really inspiring. This is my hospital here in Cusco, Peru. It is the most important hospital here, but still we have only maybe 400 beds. And in spine, in neurosurgery, we have only 30 beds in the floor. Okay, so let me please. Okay, somebody says in the middle of difficulty lies the opportunity. Here is Machu Picchu, one of the 7 wonders of the world. Actually, it's here in Cusco, so all of you are invited whenever you want to come here. It's an amazing place to visit. So I want to share some videos of some spine surgery performed by somebody else. And I like to show you how it went. If you can see the screws, some of them are not in position. And this is really, really frequent here in our city, not only my hospital, but in our city. So that arises a bit of complication for the patient and also for the surgeon, because we have to do another surgeries, and we can also cause damage to the patient. So it's never good to have a second surgery to correct something. And I think all of us will agree in that. Okay. Can you see that first moment? The left screw is absolutely loose, and the right also. So that are right questions. I mean, what happened? So we discussed, all of us are neurosurgeons, that we have proper training, I suppose. But I think in low, middle income countries, the problem is that actually we don't have, we learn on the patient, but we don't have like a school academy to work with. You don't have cadaveric sessions here in Peru, at least in most of the country. And we do the specialization usually in Lima, that is the capital of Peru. But even though the competition and there is no actually mentors here in Peru, it's really, really difficult to find one. So if we see this, we have here and can see a nexuscope, practicing nexuscope. Here was in China, actually, when I met Professor Sharif, Professor Pip, met, and we can see here for each student, for each of us, there was an C-arm, there was a cadaver, so we can practice and be guided by people that really, really know what they are doing. They have experience, so we can be there. We can actually improve our skills. But in low, medium income countries, the problem is that we don't have this kind of setup for the trainees. Okay, so what we wish for usually is this kind of settlement. Okay, we have neural navigation, we have microscope, we have C-arm, we have an O-arm. This is back in Nepal, actually, which was really impressive because Viratnagari wasn't the richest city in the world, but one mindset can change everything. So, but in low and middle income countries, our reality is a bit different, you know. This one is my OT. This is the anesthesiologist. Like you see, you don't have anything. This C-arm that you see in the picture above is one that sometimes gastroenterology let us use it and sometimes don't. Okay, so that's why we wanted, it was the picture before it, that what we got is this. Now, I know a lot of people is gonna say, but you cannot rely on technology. You know, use anatomy. Anatomy is really good and it helps for a lot of time. But actually, this, for example, is a prospective study, and we know for sure that the pedicles and everything can be 5 degrees, 10 degrees, and so in the depending of the higher or lower part of the spine. But even in this study, we can see a lot of differences, and actually everybody's different. I mean, otherwise this will not happen. Okay, so this is saying that I showed you before, just to think a little bit how this can happen. And sometimes I believe it's because we as surgeons have a really big ego that doesn't allow us to improve, because we think that we are good enough, that we think that this can happen. This is part of the curve. I really don't consider that that's true, because as surgeons, we should be the best version of ourselves. And as we are now 23, we should use all the technology, or at least all the advantage technology can give us, okay? Otherwise, this will not happen. So anatomy is really different between people. I mean, I am shorter, I'm 1.7 meters. There is a lot of people taller, shorter, bigger, thinner. So the spine change, especially with age. All people have really, really difficult spines. So what we can do to improve that is not just crying and say that this can happen, that this is acceptable. Because of 100 surgeries, I only have to do revisions in 10. So the percentage is well set. But I think that's not good enough, okay? Because I am not what happened to me, but what I choose to become. So even in low and middle income countries, we can improve a lot. Here we have two people that I respect a lot. One is Professor Garcia, the one on the left. Actually, he was a 33 years old neurosurgeon who worked with me in Child Hospital in Lima. He was really, really good in spine. And then came the idea of what I'm gonna tell you in a minute, because when we do scoliosis with him, he always take pictures of the spine in the CT scan, actual cuts. And even in Child Hospital, that it's an institute actually here in Peru, we don't have a screen or anything in the OOT, so he printed this section by section, vertebra by vertebra, so he can have the orientation, he can have the width of the pedicle and the length of the screw that he's gonna put. Tragically, he died a couple of years ago in the river. And another one that is really important for me is Professor Carlos Cárdenas. He works in probably the best clinic here in Peru, is in Lima, Auna Clinic. So when I was a trainee, I had the opportunity to spend 2 months with him and his team and see actually how ordered he was, how he performed the surgery step by step, don't missing anything. So the results are really, really, really good. But one thing that I don't like about the way that he works is that they use a lot of CR and a lot of radiation, okay? So actually what I'm gonna talk is really, really something really easy. We have known Radiant, that is a free program to see MRIs and CTs. So I will have worked with that. And the planification before surgery is always important. I have met a lot of neurosurgeons back when I was a trainee, and now even a lot of colleagues that before a surgery, they don't even know what they're gonna do. I mean, it's like, what are we gonna operate today? Oh, it's a fracture. Okay, let's do it. But I have never seen that before the surgery, they at least take, and guys, this takes maybe 5 minutes to grab the radiant, grab the CT scan, and do this. Measure the width of the pedicles, measure the length of the screws, and actually in the sagittal, we can see the projection of the pedicles in the spine that sometimes change, if you see. And actually, this is something really, really easy to see, but a lot of people it doesn't do it, okay? Because when we see a fractured spine, sometimes the angulation of the pedicles, even though the vertebrae itself have changed. So that is a problem, because by anatomy, we know that's going to have a away. And okay, guys, you're gonna say, but you have a C-arm in the OT, you can see it also. Sometimes we don't. And besides, when we take a picture and a picture and a picture, we are more exposed to radiation. So this is a really, really easy solution using a free program that only will take us a couple of minutes and will improve our surgery. From over 300 surgeries that we have performed with my team, only 2 screws were not in position. One of those was this, that is lateral to the vertebra. We have to perform again. And one that they don't have the image, it was a little bit medial. And the patient presented auriculopathy, so we have to, the next day, start to do it again. And that was private practice, so it was a problem, okay? So as conclusion, radiological planning is advised because first is cheap, decrease the possibility of an error during surgery, reduce the exposure to radiation because you don't have to see every step of the way, reduce surgical time, and allows to use the proper width of the screw. You know, as width as the screw is better for a patient and make a safer surgery. So thank you all. And if you have any questions, please.
Thank you. Any questions, comments?
I'll
have
do
a
short
question.
comments. I think what you are addressing quite fundamental principle. You know, you have to prepare yourself for surgery. You have to prepare yourself. You have to see the scans. You have to do the planning before surgery. And if that's not the case, and if somebody is forgetting to do that, that's obviously substandard. So that's a good point, and thanks for addressing that. But it is really fundamental to prepare yourself for surgery, to see your scans before you go and before you operate. That's my comment.
Thank you, Nikolai. Yes, Marcus, your comment.
Yes, I would like to ask him. I think it was a great message. Technology, technique can compensate the lack of technology. Is that what he is meaning? Technique can compensate the lack of technology in a surgical field.
Yeah, I think we cannot only rely on technology. That is the message. But if we have it on our hand, we should use it. Because like I said before, anatomy is not the same for every person. I have operated sometimes really old people, so all the anatomy parts are completely changed and sometimes really difficult to address all the points to do or perform the surgery itself. Now, I asked the other presentation because I think here in Peru we have a lot of opportunities because public system actually covers everything that we can ask. They don't have that problem with the insurance, the private insurance that they always try to don't give us all we need. But in public hospitals, the problem is that a lot of people here has forgot that you use everything. I mean, the screw that it was not in position that I showed you before. It was a day that we are doing surgery. I was alone with just a med student. We don't have CR. We have interpretive X-ray, and that also failed. So what Professor Piff says, it's really, really important to be prepared to do the surgery. And sometimes here in low medium income countries, especially in public practice, what I can see, what I have seen, is sometimes we think that we know enough, and we think that at these poor people at this public hospital, we don't gonna have so much problems as in private, you know, and that's not fair for people. Believe me, I have seen a lot of my colleagues do a lot of really, really bad surgeries. And it's not about how much time are you spending, or how much time do you have as neurosurgeon, but how much do you really care about what you are doing? Because sometimes, let's say, the percentage, the middle margin of error that sometimes are presented in the books and everything are an excuse. I mean, for 100% of my surgeries, I have 10% of complication. And this is in the middle rational that it can be. But I believe as neurosurgeons, we should decrease every time, with time. I mean, learning from somebody to know first. And if we don't have the opportunity now, as these meetings that we are now, I think it's really, really important. Before, let's say 30 years ago, we don't have the opportunity to meet as we are doing right now. I mean, there are people from Brazil, Nicola is in UK, Professor Sharif is in Pakistan, but right now we are all together and we are learning from all of you that are really, really good. That has never happened before. So our ratio of success in every surgery should be better and better every day. Now, in my hospital, we are buying a 2 million soles new C-arm. It takes me 3 years to get the money, but the government has it. So we're gonna obviously have everything, and it's gonna be much better. But as Professor Massini says, we can not only rely in technology, we have to be prepared, and prepare studying anatomy, we prepare studying the patient, prepare studying the technique. Like Professor Campos says, sometimes between surgeons, there's a difference of opinion. And sometimes older people, I have seen, especially here in Peru, old people say, I have a lot of experience. Yeah, but experience doing how things. Because I can have 30 years of experience doing things wrong, and that is not good experience. So the message, I think, for young neurosurgeons, it will have to be in our A game, every time, every patient. We cannot allow us to fail, because it's the life of somebody, it's the spine of somebody. And we know it's not only the cause of doing the surgery again, but it's the psychological stress for the patient, it's even for ourselves. So as I present now, I think the importance of what I have to maybe pointed is that using free and easy technologies that we all can have, we can, like I said before, diminish our time of surgery, diminish our time of exposure to radiation, and improve our results. I think that's what the message. Thank you.
Thank you. And we have one question from the chat from Mohammad Jahazeb. The question to you regarding reducing radiation exposure for percutaneous screwing. Is there any special tricky recommendation? Probably.
I think what can, if we can use this presentation is the length of the screw. We already know how it's going to be our top. I mean, we're not going to pass the vertebra because we know the length. Because I have seen, look, what I'm telling you is a lot of people I have seen when I was a trainee, and even now some colleagues, that during the surgery they don't know exactly how long it's going to be the screw. So they are taking picture through picture through picture to do that. If you know exactly where you are and how you want to do it, in my experience, we use, before the surgery, we take one picture with the C-arm. Obviously, when you put the cables, we take one more. And when you pass the pedicle, 3 centimeters usually, then we don't have to take any more pictures because we know how long is going to be the screw, so we don't need more. And actually, these kind of things I learned from Professor Piff, I learned from Professor Sharif, that the most important thing is the anatomy. If you know the anatomy, if you know how to position it, the RC arm is also really important. Because in my hospital, for example, sometimes if you are lucky, you have a good technician, he's going to give you a good picture, and sometimes don't. And when there is a person that doesn't know exactly how to do it, you have to teach them. So we have to not only be neurosurgeon, we have to be also a bit of technician, a bit of nurse, a bit of everything, so we can improve and teach also. And don't get mad with people, because a lot of us, we have been really, really lucky to be able to travel, to know people, to learn from the best. And a lot of people don't. But I think it's our duty to teach them patiently so they can learn too. So planification before surgery is going to help us to reduce the exposure, I think, especially in percutaneous, with the length of the screw. We don't have to be taking pictures every time. I think after you pass the 3 centimeters of the pedicle, you can freely put all the screw in, and that will be great.
Okay.
Thank you. I have a comment, please. Thank you. Thank you, Professor Sugar, for your talk and the important point you touch. The reality are similar in our practice in Africa, as spine surgery is increasing during this 10 past years because of many traffic. We have lots of trauma surgery because of traffic accidents. You point out different anatomy also between people. You know, in African people, particularly women, have exaggerated curve lumbar, so many problems of facet of dish disease. And here we see in many Africa countries improve the surgery, spine surgery. We have some center here in Africa, West Africa, in Benin, Togo, Ivory Coast, in Senegal. So we have center who perform spine surgery now. But it's important, I know, to have to plan the surgery before the radiological team before the surgery. But as you have said, it is not always possible. Sometimes here the radiological device machine are in the capital, and most of people come from far. Sometimes they come also with the city. The city has already done, or the X-ray is already. I personally have to operate some patients with only the X-ray because we have not time to look for a city. So it's important, as you say, also to have a good training for the. In Africa, we are not a lot for spine surgery, and we know all of most of us we perform that, and it's important for us. So as we are doing this last year to increase the number of courses in surgery. Here in Abidjan, we have a lab, we have the anatomy lab. So every 2 or 3 months, our trainees come to the lab to see how to put screws in the vertebra, or how to do some approach, and how to use some implants. And this is useful because sometimes I was in travel last month in the country. The surgeon was doing surgery, and he has the failure of the CR. So during the surgery, all the screws were not put. So you have to do by anatomy, anatomy skill. So I think training is important. Is why the reason why we have done many courses in Africa, Central and West Africa. We have done over 5 courses in West Africa. This month, with Nicolas, we have a course in Senegal. We have a cadaver course in Senegal on 19 October with 40 trainees to improve the skills in spine surgery. Thank you for your thoughts.
Thank you. I think it's probably a time a little bit to conclude some points. I just want to say my personal experience. I would say that what all the speakers was underlined is very similar. The problem is similar. The advantages and the limitations. I mean that's I could say that's the same problem in our Russian reality now from the point of view of different, for example, coding guidelines, even different societies which provide their own interest via the authorities. And for example, in our country couldn't find the solution sometime how to promote the spine problems, spine surgery in one way, because the people couldn't be conjunct and decide. And as I told already, we have the same limitation in technology, of course, but even what was the last speaker told, we even have the same problem with IT possibilities. I mean, we also couldn't have Radiant, for example, we're limited now, and we couldn't properly work with some imaging, intraoperative, etc. But if just to see some advantages, I think the WFNS platform is what's exactly possibility and advantages to you to find the real solution, to find the decision how to develop in the proper direction. That's why I'm very thankful for all the speakers, and please any comments and for the conclusion, Nikolai, please.
Yeah, I think it was a good session, and definitely there were very reasonable questions raised, and obviously neurosurgery, spinal surgery is not equal in different parts of the world. There is places where there is more available. There is places where there is barely anything available, and I think this is one of the strides of the WFNS to try to equalize things as much as possible. I think we are far from being possible to say that we are winning that battle, but it's a long-term battle, and we will continue.
Thank you.
Thank
you for everybody. Thank you all the speakers. I think our common gratitude to Professor Salman Sharif with his birthday. We like this guy. I think he has a nice time today. And thank you all the moderators, and see you next time, and probably in Cape Town. Yes.
Yeah, soon in Cape Town, and maybe I will be with Hadara next week.
you.
Bye-bye. Thanks.
All the best. Bye-bye.
Thank you, everybody. Thank you.